Hi, everybody. Welcome back to Ask an Addiction Specialist. I'm Bob Weathers and really happy for you to join me again this week. My work is in recovery coaching, and the focus of this weekly podcast is on addiction and recovery. Our topic last week was restoring hope in recovery, and we had a very rich interaction with you as our audience. And we made it halfway through the material that I had prepared. I co-presented with Odie Martinez, who's here in the studio today with Austin Armstrong as our co-producers. Thank you, Odie and Austin. And we're going to actually pick up on Restoring Hope in Recovery Part 2 next week. But we have a special treat today, and it gives me great joy to be welcoming my dear friend and longtime colleague, Dr. Cheryl Bildner, who's piping in directly from New Hampshire. We're really happy to have you with us, Cheryl.
Hi, Dr.
We refer to each other as Dr. B for Dr. Bob and Dr. C for Dr. Cheryl. It's going to be hard for me not to call you that.
I know, right?
Just a word about Cheryl, and then we'll dive into the material. Cheryl's been working for the last 20 years as a clinical psychologist in the Mount Washington Valley in New Hampshire. I lived back there in the 2000s, and we worked together out of the same office, and we've had a friendship during and continued since then. I've been really blessed to have you in my life, Cheryl. Really grateful for our friendship.
Thank you, and likewise.
Yeah, thank you. She was my survival when I was back in New Hampshire in more ways than one, that's for sure. A couple things to kind of give context for our conversation, and then we'll dive in, Cheryl. In the last, just the last week or two, there's so much information in the media about the opioid epidemic. A couple of things, the Center for Disease Control. I read two different announcements in the last week, and Cheryl, you may comment on these when you get to your presenting material and so on. Two things really struck me. First of all, I just read it this week, is that the for the first time, death from overdose with opioids has now transcended or surpassed auto deaths for those under the age of 50. And so more people are dying from overdoses with opioids than from car accidents, which is, I don't know, for sure, that's just a really striking statistic to me. Another very painful statistic that I just read about last week is that the number of deaths owing to opioid overdose has doubled in the last 15 years, which is a relatively brief period of time, and in fact in the time that you and I worked together, Cheryl. So during that time, the overdose rate has doubled, which that's nationally. And then I read another statistic that will place special importance on your being with us, Cheryl. I work here in Southern California with, as you and I have talked about it, with clients from all over the country who come here to Southern California for treatment, most of which are either in treatment for heroin addiction or methamphetamine addiction. But many of them come from the eastern part of the United States. And I've had clients from both your state, our former state together, New Hampshire, as well as West Virginia. And although West Virginia and New Hampshire are small population-wise, they're the number one and number two states in the country in terms of per capita deaths owing to opioid overdose. And so it gives a special, I think, poignancy to your being with us, Cheryl, is that in so small a state as New Hampshire, is that it's number two in the nation in terms of the per capita rate of deaths owing to this horrible epidemic. So Cheryl's with us today, and in the context of restoring hope, we're going to be talking about the work that you're doing. I do want to preface this by saying, and Cheryl and I have talked about this, is the work that she's doing in New Hampshire is innovative for sure, and I'm very curious to talk into that with you. And it may be not uncontroversial with some of our participants who are viewing today, because we're going to be talking about the use of medication-assisted treatment and how it's saving lives in New Hampshire and in West Virginia and across the country. And depending on what treatment center one works at, there are treatment centers across the country, including here in Southern California, that are utilizing medication-assisted treatment. There are plenty of treatment centers that do not utilize it, and we'll talk into all of that. And I would only ask that you retain an open mind just for the sake of gathering more information. I got a chance this past year twice to speak to national groups of pharmacists and learned a lot about medication-assisted treatment because it's not been my kind of front yard here in my own work here in Southern California, and it really helped to illuminate things just for me to see the range of possibilities and how anything that is saving lives is worth our considering. And so that's a bit of a preview, Cheryl, and I want to invite you to introduce anything more you'd want to about yourself, and I'd just like to dive in with you just to have an informal conversation about the work you're doing, anything I can do to support you, as well as to illuminate our listeners here primarily in Southern California. So welcome, Cheryl.
Well, thank you. I want to just start out by saying I live and work about 3 hours north of Boston, and it's a pretty rural area.
Yeah.
If I come in and out, it's because we don't have stable internet connections.
Yeah.
Believe it or not, I know you're in a metropolitan area, and it's you probably don't think about it, but finding a stable connection has been a challenge.
Thanks, Cheryl. Thank you. Yeah.
So I'm about 3 hours north of Boston, and it's a resort community. It's a lot of mountains, a lot of skiing, a lot of hiking. And the area has been hit hard by the opiate epidemic. And I first was introduced to direct treatment of individuals suffering from opiate use disorders about 5 years ago through a medication-assisted treatment program.
Okay.
The epidemic is severe, and there are a lot of people dying. And what I subscribe to is a philosophy called the harm reduction model.
Okay, great.
So it can or cannot be abstinence-based, but the goal is to reduce harm. And obviously, the ultimate goals are to save lives.
Yes.
And we're losing, young people every year, and older people as well. But the young community has been hit particularly hard. And our goal is to reduce deaths and reduce harm and get people up and functional again. Now, in a rural area, there are a number of obstacles to treatment.
Okay.
Many people don't have health insurance. Many people don't have access to transportations. If there is a lot of DWIs and licenses have been revoked. Some people can't afford cars. People are hundreds of miles away from healthcare facilities that can actually treat this disorder. The governor just rolled out a new program to try to increase access to clinics around the state.
Good.
But ultimately, we're over, the closest inpatient treatment is over an hour away for most people, if their insurance covers it and if they have insurance. So one of the things that I've become involved with is medication-assisted treatment programs, and these are either standalone clinics or they're run through the primary care practices around Mount Washington Valley or around the state. I'm in Mount Washington Valley. And the medication that's most often prescribed is Suboxone. And Suboxone was approved by the FDA in 2002 for the treatment of opiate use disorder. It's a brand name, and it's a partial agonist, which means that it binds to the receptor and it helps to reduce the symptoms of opiate dependence. And the way I conceptualize it is if you think about think of Suboxone as a pacifier, and it's just binding into the receptor so the individual doesn't go through withdrawal, because so much of what perpetuates the cycle is that fear of withdrawal and individuals doing anything to avoid those symptoms. So Suboxone replaces the street drug to prevent withdrawal. And it consists of two substances, buprenorphine and naloxone. And the buprenorphine is the substance that binds to the receptor. It fills and prevents the withdrawal. And the naloxone is an opiate antagonist. And what that means is that it blocks the effect. So if you're taking Suboxone and you relapse and, take a pill or shoot some heroin or something, you are going to go into immediate withdrawal. So you cannot get high when you're taking Suboxone. Is that clear? Do you follow that so
Yeah,
far?
yeah. So let me just, if I got this, the buprenorphine is going to address the withdrawal. It reduces the withdrawal, which is so many of my clients talk about. I think the popular misconception is that people like getting high. And so many
Yeah,
clients I see, and I assume the same with you, say that that's a long time ago that they got high. They just don't want to get sick.
they don't
And
want to
yeah,
get
yeah,
sick,
yeah,
and that's
yeah,
the
yeah.
big,
Okay,
big problem.
okay,
So Suboxone prevents you
yeah,
from getting sick.
okay,
And
okay.
some people, will argue, well, you're just substituting one drug for another drug. And I don't disagree with that. Again, harm reduction. So our goal is to save lives. If we can get someone on Suboxone, they're less likely to overdose
Okay,
on street drugs. And you're also, when you're taking Suboxone, I've seen people go from non-functional states to more functional states.
okay, while on Suboxone. Okay.
Yes.
Okay, good. Yeah. Do you have any statistics just off the top of your head, or if not statistics, just kind of an overall impression in terms of, I'm not even sure how to ask the question, Cheryl, in terms of how many lives are saved, or what the, I don't know the numbers on this, but for example, the overdose deaths owing to heroin and now fentanyl and so on, versus what you're talking about with this other drug, Suboxone, which prevents greatly the risk of overdose. Any sense of, it just seems like that's an important piece of information of how effective it is in saving lives.
I don't have a particular statistic, but I would imagine it's incredibly helpful in reducing that number for multiple reasons. You're not going to go and seek street drugs where you don't know what's cut into the substance. One of the problems that's causing the deaths such a high death rate is that fentanyl and carfentanil are cut into the heroin, and they're so toxic. And some of the first responders are actually experiencing reactions from coming onto a scene of an individual who's overdosed on fentanyl or carfentanil through touching the substance or inhaling it, and it's so toxic.
Yeah, I've read about that some too. It's really disturbing. Yeah, I found this statistic in the article that you sent me. Cheryl sent me an article that just came out in November of this past year in the Annals of Internal Medicine that's looking at kind of the cutting edge of developments with what we're talking about here in terms of using medication-assisted treatment in opioid use disorder. And I just read this one sentence because it stood out to me. They said in the U.S. studies of opioid overdose deaths, buprenorphine is found in fewer than 1% to 2% of those deaths. And so it seems to me that people aren't dying of overdose with this.
Correct.
I'd be very interested to see. It stands to reason what you're talking about. And certainly when I met with the pharmacists back last year in Salt Lake City, the National Association, and then in the fall I was in Austin with the Texas Association, it's so much a part of what pharmacy is doing right now, is providing education. And it really is in the same spirit that you're saying, Cheryl, which is to save lives all over the country. So,
and there's also, you have to think about the secondary issues as well. If someone's using a needle, there's a risk of contracting hepatitis C. So that can save a life, There's increased crime rate and more violent crimes associated with, individuals trying to get drugs when they're, going through withdrawal. That can save lives. So I think it's a difficult thing to measure in all, the full effect.
It'd be interesting, and I don't know who's done this. I imagine somebody's done this. Sometimes I look at the statistics, for example, of the U.S. Department of Justice, and looking at they'll be able to kind of extrapolate a number on terms of what cost it is to society for kind of incarcerating people owing to substance abuse or addiction, and they'll come up with these numbers that are just stunning to me, just billions and billions of dollars.
It's stunning.
Yeah, it just kind of blows me away. And I can imagine that you could come up with, not only in terms of dollars, which is one metric, but also in terms of just human suffering, the kinds of things that you're talking about addressing in terms of saving people's lives, keeping families together, keeping people employed, reducing crime. You could keep going on and on with that, these kind of intangibles that really make a difference with this kind of intervention.
And the community I live in is a small community.
Yeah,
So when
yeah.
someone does, overdose and passes away,
Yeah.
more often than not, have had some interaction with that
Yeah,
individual.
yeah.
And it's just so sad, and it really hits the community hard. And, if we could prevent people, from dying through the use of medication-assisted treatment.
Yeah.
I know there are other philosophies, but I have to, and subscribe to the one that,
Yeah,
is effective.
let me ask you a question, Cheryl, and I hope this isn't premature, and if it is, we can
Sure.
bookmark it for later in our conversation. But I'd be very curious about, in your experience there in the Mount Washington Valley, in terms of other philosophies. You and I certainly are both aware from our work of 12-step approaches. Many of the centers I've worked with rely heavily on AA and NA and Al-Anon and other resources and so on. I'd just be curious what your experience is working where you are in New Hampshire with competing philosophies. That would be one perhaps that has major reservations about the use of these drugs. Although I've talked to people that are in the program, 12-step programs, where they found meetings that there is support for them being in medication-assisted treatment. What's been your experience, and maybe to kind of, I don't know, give voice to the different philosophies and just kind of recognize that there's some differences of opinion out there?
Absolutely. So again, going back to something I had said earlier, is that transportation is a really big issue in a rural community.
Yeah.
There's no public transportation, and someone who's, at or below the poverty line can't afford a taxi if they can find a taxi service.
Yeah.
So getting to meetings, yes, you can hook up with a sponsor for sure, and you can go to an AA meeting. But again, we lack the meetings. There's often a lack of anonymity at the meetings.
Yeah, and a small,
so people, So people, don't always feel comfortable going, and it's hard going into a meeting when you see someone you know or you used to use with, and you have a history with. So, and there is a lack of anonymity. So there are multiple obstacles, and many of the medication-assisted treatment programs require that individuals who are part of the program have to complete, a certain number of tasks of, quote, self-care a week. And it may be, a therapy appointment. It may be going to an NA or an AA meeting. Or, it may be, meeting with a physician to address some health issue that they may be having.
Yeah.
But there aren't, I can't give you a specific number, but it's not like, San Diego or in LA. Right. The number of meetings, they're not more than maybe 2 a day in a 50-mile radius,
Yeah, I believe you. I keep forgetting about the rural nature of what we're talking about. There's some specific barriers to treatment in the area where you live that would not be the case in a kind of urban area, and that's an important variable, it seems like to me. I know that you may be headed this direction, but I'm curious about the application of online resources in this day and age. Cheryl, before I ask that question, before I go that direction, somebody's put a question or a comment up here. Can I take a quick look at it? Let me just take a look at this.
Yeah, absolutely.
This person says, I really appreciate this compassionate approach of harm reduction as part of many of the ways we can help people. Love any approach that reduces death and suffering, and it should be embraced. So you got one fan out there, Cheryl. That's great. I feel very similarly. I feel like anything that can lead to healing and the saving of lives, I'd really like to give it ample, attention. That's for sure.
Absolutely. No, so I appreciate that.
Yeah, thank you. Thanks for that.
Bob, I just want to pipe in with one other comment.
Yeah.
We lack mental health, behavioral health, addiction service infrastructure up here. So there are people who can't get access to care, and that's a really big, it's a really big problem. And you know how difficult it is, to call for help and to make that call and to reach out, and many times people know they have a problem, they call clinics. And it's not uncommon for clinics to say, we really want to help you, but we don't have staff. And it's really hard to imagine when you're in that state and you finally acknowledge you need help. and you can't access help.
Yeah, I can't imagine how frustrating that is, the limitations, how frustrating it is for care providers because they're limited resources, how frustrating it is for that client. There's so much social stigma and personal shame associated with addictive disorders of any stripe. So to finally get the courage up to reach out and to find out that there aren't services available or that they're not really practically accessible because of finances or transportation, all the things that you're naming, really creates a lot of barriers. That's for sure.
And to extend on that, there's also around the state, a lot of people are promoting the use of recovery coaches in treatment. But I personally feel as though we lack stable recovery coaches. The epidemic is so new up here that and there's been a lot of federal money pumped into the state to train recovery coaches. And I think it's a wonderful opportunity, but self-care first, right? So you have to make sure you're in a stable place and you are able to effectively take care of yourself before you can take care of another individual.
So you're talking about people that are doing coaching that themselves are in recovery?
Yes.
Yeah, got it. Now,
and that's a great model. It's a great model.
So much of the work I do here in Southern California is very similar. You get a lot of people sometimes there's a bifurcation maybe between clinical staff in a treatment center and recovery staff, and the recovery staff themselves are most often in active recovery, and the clinical staff rarely are. It ends up how it falls out. And I totally get what you're saying is that if you get people prematurely involved, I mean, it's a noble thing, and altruism is one of the healing factors in for example, 12-step groups and so on, but you got to make sure that you got your own stable recovery in place. And I can imagine, because it's so new in New Hampshire as well as across the country, it's easy to kind of rush this process and end up with people that themselves are not stabilized. And I can speak firsthand, because you know my own history with addiction and recovery, is that early on it was triggering for me to be working with addiction, which is why I didn't work with it early on, is that I needed to kind of get established, and working with people that are actively in addiction can itself be triggering for somebody who's early in recovery. So that would be a warning sign for sure.
Absolutely. So one of the things which you had alluded to a little bit ago is I work for a company called Boulder Care. And what Boulder Care is trying to basically mainstream medication-assisted treatment program. It's a healthcare startup, and it's operating on a national level.
Great.
And the goal is to have people obtain access to medication-assisted treatment within 24 hours of reaching out, which is a big goal.
It's a big goal. That's impressive.
And this is done through telehealth as well as through supporting local endeavors. So, for instance, Boulder has recently partnered with a local community health center. And one of the problems is the behavioral health needs of the population is so great. So, maintaining insurance, maintaining housing, maintaining, state support. There's so many obstacles, making sure, if they children that they're getting to school, that they're fed. There's so many levels. So one of the big obstacles is, providing medication-assisted treatment, but doing so in a responsible and in an ethical manner. So you could provide these ancillary services, which are critical. It's hard, it's hard enough to get off drugs. Imagine getting off drugs without having a roof over your head. Or knowing where your next meal is going to come from, or how you're going to get to your next doctor's appointment. So one of this company that I'm working for is trying to create, they're creating, but they're supporting local clinics as well as creating a platform that can be used on your phone. So some of these services can be prescribed and provided through, your phone. And there'll be providers, there'll be nurses, there'll be recovery coaches, as well as therapists involved. And the goal, again, is to prevent these overdose deaths, because, again, it's so hard to access treatment. And initially, when a provider is able to prescribe, they are only allowed to prescribe 30 patients, and there are waiting lists. And some clinics won't take take on more than 30 patients because they can't provide all of the services that are necessary.
Right. Cheryl, there's a question that came on just as you were speaking about this telehealth component, and I'll share it with you. And just I think it's implied in some things you've said. This person said, for Cheryl, in your rural area, is access to online recovery meetings and coaching, etc., is it not available due to people not having computers? Is that an issue? Computers or cell phones or whatever the medium would be.
So this is interesting,
Okay,
and this is something we've actually looked into.
Okay.
So we've done a number of marketing research focus groups, if you will, on individual meetings with individuals. And what's interesting is that everyone had a cell phone. Yeah. The obstacles are they can't always pay for service, and they can't always access the internet. So one of the things that Boulder Care, we're brainstorming, we're trying to come up with innovative ways, is if we can get individuals to, engage in X number of treatments a month, well, maybe we can then provide them, a phone card or an internet service for the month. Their phone numbers won't change, and that's a big thing. Some clients I have 5, 6, 7 phone numbers for, and I go through trying to figure out which one is the most, up to date.
Yeah.
That's a really good question. Everyone seemed to have phones, whether or not they were in use and whether or not they could access the internet. And even myself, I went around to 3 different places this evening trying to find a good internet connection. So.
I appreciate our talking about these pieces. I think there's some things that get taken for granted in a metropolitan area that don't pertain or are very different issues that arise in a rural area. And it reminds me of Maslow's hierarchy in a sense, is it doesn't make sense to talk about recovery if I don't have a roof over my house and my kids are starving. It's just, it doesn't make sense to talk about treatment, no matter what the form of treatment is, if I don't have access to it, or if I don't have, if I don't have access to internet, for example. And I really appreciate the fact that Boulder Care and what you're doing with them is really addressing just kind of these really kind of basic foundational issues that if those aren't in place, then the therapy, whatever the treatment is, falls flat on its face. So I really respect that a lot.
And it's been I've been working with Boulder Care for about 6 months now, 7 months now, and it's about, everyone, we're from all over the country, New York, California, Washington, and it's really Massachusetts. It's really a neat process. So we have technology people, we have business people, we have healthcare people, we have physicians, addiction specialists, and we're all working together to create this. And the neat thing about it is that we're using actual individuals to help us create the program. So they're giving us feedback on, trying to make the best program possible. Because the individual who just wrote in that question, we didn't know if everyone had phones. That's a really good question. Everyone seems to have phones. Everyone we've worked with seems to have a phone. It's just the access, of communication.
There's something that's implicit in our whole conversation, Cheryl, and I'm really struck by it. And you and I have both been clinicians for years and years, and I have certainly found clinically and discovered firsthand for myself in terms of my own experience around addiction and recovery, is that there's so much, and it's even understandable to me, there's so much of a kind of a punitive mindset that whether it's at the level of the family or at the level of criminal justice or whatever, and I feel like it feels like our conversation is devoid of that kind of punitive or stigmatizing kind of attitude. I'd be interested for you to comment on that, what your experience is.
I think it's so important to be a well-trained provider, and it's really interesting because frequently you see relapse as part of the recovery process. And it's, again, looking at it from a harm reduction model. What happens when, you're triggered or you're increasing stress is your automatic go-to is, a drug. So people may be on Suboxone and going through an unusually stressful time and may relapse.
Yeah.
Many providers, and again, different schools of thought, even within the medication-assisted treatment community, would be punitive and,
Yeah.
cut back on the Suboxone. So that's going to really help. If you cut back and then you're having cravings, what's going to happen? You're going to have more cravings.
Yeah.
Or they'll make individuals come in for more pill counts or more urine screens or more visits. Well, someone working, a $7.50 an hour job
Right.
who has to take, several hours off from work without a car to get to the clinic, to have a pill count, or else, they're going to be booted from a program. That's punitive.
Yeah.
And the model that Boulder Care subscribes to is, let's try to help people rather than be punitive. Let's look at the situation. What caused the relapse? What can we do to help prevent that from occurring in the future? What do you need to prevent from relapsing? And that's the Boulder Care model. It's how can we help you rather than why be punitive? And what we do is we measure functionality. We look at people often say, does Suboxone work? And I always respond, well, define work. What do you mean?
That's good. That's good.
Right?
That's
I
Dr.
mean, you're
C.
not off a drug, right? Not abstaining, but many people, are able to maintain employment. They're able to contribute to society and to the community, better events for their children. And that's what we want. And that's what we want for the next generation. And, there's a lot of young people affected with a lot of kids in the household. And we want to bolster supports rather than be punitive and remove, the support.
It's funny something, both you and I went through PhD programs in clinical psychology, and I'm assuming this is the case for you, and I know it's the case for me, is that I'm just going to speak for us. Our training looks at almost any disorder on a continuum. There's a lot of gray and very little black and white in clinical psychology. And so it was a peculiar thing for me to encounter, especially firsthand, when I myself got addicted and got into treatment, that there's a lot of black and white conversations that go on, and they're not continuous with my own training in clinical psychology nor my practice over the decades, and I don't presume for you. And so as you're talking, you talk in an idiom that's very familiar to me, because both of us have backgrounds in clinical psychology, but I found a lot in the world of recovery from addiction that there's this, you're either addicted or you're not, you're either abstinent or you're not. And I really appreciate the tone of what you're saying, and I also appreciate very much the tone of this article that I read that's just hot off the press, that it really looks at things, I feel like, in terms of what I just talked about, in terms of gray areas, and it finds different levels of success. I even liked the way they talked about, rather than using the term relapse, which has such a pejorative connotation.
A negative connotation,
What's that?
Yeah, negative connotation.
Right, and so they used other things like non-adherence, or I even like this one, an unexpected finding. I love that. Just for me, it humanizes this in a way, and I know firsthand, being on the receiving end of those kind of diagnostic comments, that it makes a huge difference in terms of motivation to continue onward in one's recovery, whether the clinician, the terminology really does matter.
And this article is in the Annals of Internal Medicine.
Yes.
And two of the authors are part of Boulder Care.
That's wonderful.
And,
that's wonderful.
So the word that comes to my mind is compassion. This is such a stigmatized population, group of individuals. I know, interestingly enough, I don't have a substance abuse history personally, but to be in this community, experience it, and witness it, it's just... I feel like, how can you not be compassionate? I mean, again, people are dying, mothers, sisters, brothers are losing their relatives, and it's just, it's tragic. It's unnecessary. I
read a statistic that came out of a study. It was actually out of New York a few years ago, Cheryl, where they said that it was a nationwide study, but it was actually put on by a group of attorneys out of New York. And it was a nationwide study, and that one out of 1 out of 3 respondents had somebody in their direct, no, excuse me, 2 out of 3, got it wrong. 2 out of 3 respondents had somebody, these are adult respondents, 2 out of 3 had somebody in their immediate family that qualified for substance use disorder. So 2 out of 3 acknowledged it, whether it was a brother or a sister, mother or father. But the more telling statistic was the accompanying one, which is that 2 out of 3 of respondents said they wouldn't talk to anybody outside of their family of origin about the addiction because of stigma. Now that one kills me.
Shame.
That one kills me. Yeah, that's a painful statistic. And so anything that we can do to reduce the negative judgments that go towards addiction. It's so much of the work that I do, so much of the work you do, and it's implicit in the way you've always talked to me, Cheryl. There's never been any shaming tonality from you. It's love and concern, but it's clients will respond to compassion, and they can smell out if you have some
Absolutely.
kind of judgmental dogmatism or agenda behind what you're saying, and they'll tell me that. They can tell. They can tell.
Absolutely.
Even well-meaning clinicians that are looking down their nose, they can feel that, and that's not a good thing.
Right.
Yeah.
Absolutely.
Yeah.
And it's such a big problem, and it just affects so many people. And you know, I feel an obligation, you know, to help and be a part of, you know, the treatment. And again, this wasn't my area of specialty. I got, you know, asked to run a group 5 years ago.
I remember.
Yeah, I was like, I'll try it, you know.
Yeah.
And I actually, you know, I enjoy working. It's a vulnerable, it's a real population. It doesn't, you know, when you're withdrawing, it doesn't get more real, you know. And it's, you know, I feel.
Can you give me a sense, Cheryl? We have just a few minutes left. I don't know if it's possible to describe this in words without images, but you've really piqued my curiosity. If I'm going online and I'm in recovery from let's say pain pills or something like that, and I sign on with your group, with Boulder Care, and they have an online kind of telehealth component, and I've got a cell phone that I'm fortunate enough to have it hooked up to one of the providers. What might I expect? What kinds of services might I be able to access via my cell phone? I'm very curious about this.
Well, I mean, for specifically for Boulder Health, this is a program that we're actually creating, and it's rolling out as we speak. Our long-term goal is to provide comprehensive services for substance use disorders. So, meeting with either a physician assistant or a nurse practitioner or a prescriber, you know, having there may be supervised at-home pill counts, supervised at-home drug testings. One of the interesting things that I struggle with, and I hope I'm not getting, you know, too specific, is that, again, talking about the punitive nature, observed urine, you know, is a big thing. And I can't think of one other population in which we have individuals undergo observed urines. And I find that just, I don't know, demoralizing, dehumanizing. I just, you know, I find it to be an invasive.
I want to respond to you briefly. I've worked in settings where I know that's going on, and it's kind of par for the course. There's one of the things I discovered being on the patient end of this, Cheryl. I don't know that we've ever spoken of this, but there's something about, you know, there was a study out of Johns Hopkins, out of the School of Public Health some years ago, that they were looking at the various categories, diagnostic categories in the DSM. That's for our viewers, that's the Diagnostic Manual of Psychiatry. And they looked at the various disorders, and there was a study of looking at which of these disorders, how do they rank in terms of negative social stigma. And probably not surprisingly, substance use disorders were at the very bottom of the barrel. Far better that I be autistic or schizophrenic or any of the other disorders than to be addicted. And what I want to say is that when I myself got into treatment and I was in the hospital for detox, I can remember I didn't think there was any precedent for this for me in my life, where medical personnel and other treatment staff, they were just kind of given rights to your body, to your privacy, to your history, to your emotions. And the conventional rationale is, well, we can't trust you because we know that you'll sneak a urine test or you'll do this or that. And I understand that. I'm not naive to that. But there was a kind of pervasive kind of cavalier attitude. And Cheryl, you know me. I'm modest by nature. That was overwhelming to me to have people just completely remove any sense of my own kind of personal boundaries. And I think people vary with that. And I may be on one end of the continuum, I don't know. But that really was difficult for me.
Absolutely.
And even when compliant, there was this kind of assumption of guilt that I was out to sneak away and I've got this, conniving little thing going on. And I take addiction very seriously, and I know it from the inside, but I did not find that attitude, which was pervasive, I did not find that supportive of my early recovery.
Absolutely. And there's just, again, punitive, it's this mistrust. And, respect earns respect. I mean, you treat people with respect. And, if someone who's using wants to fool you, they're going to fool you, But, if they make an effort, again, I'm not naive to it either, but I'd like to not observe urines, you know.
Something I appreciate about the article that you sent, Cheryl, Cheryl, I should ask you, is this article available for viewers if I were to send it?
It's available online. We through the Annals of Internal Medicine. I could send you the link.
I have the link, but I want to make sure that that's not inappropriate for me to forward the link you sent me. Is that, I just want to respect the journal. Is that?
No, I think it's okay. I think it's okay.
Okay. Yeah. I know that to download it, I was going to have to pay a certain fee, but I was able to read it, and I appreciate that very much. With your permission, then I might want to forward this article because I think it's very readable, and they discuss probably a dozen different kind of relevant points, most of which you've touched on today. One of them we're just talking about right now. I don't know enough about this because it's never been in my domain to do the testing, but I really appreciated it was the sensibility in the article around testing. And they talked about alternatives that would be far less invasive of particularly sexual privacy, like, for example, saliva tests. I've never really thought of that.
And that's actually in the process. And what the ultimate goal, and we're working with companies right now, is to develop at-home kits where you can basically spit into a container, you mail it in, or you put it up to the Skype and you have the individual read it, with the camera, and it can say what you're positive or negative for. Absolutely.
Yeah. As long as I can do that in privacy, I don't want to spit.
Absolutely.
I don't want to spit in public either.
No, I get that. I also encourage people to check out Boulder.care because it's
Boulder.care?
Yeah, Boulder.care. It's like Boulder as in the city. And it's cutting edge. It's
great. That's awesome.
Technology. Yeah. And it's innovative. And again, in rural areas, we use telemedicine for medical treatments. The local community health center is connected to a larger medical center, and they treat the hepatitis C patients through telehealth, and it's already happening, and we're working to get telehealth and behavioral available to behavioral health services and addiction medicine.
I'm really touched by all that you presented today, Cheryl. I want to share a couple things with you. A couple of people wrote in. One person wrote something specific that I think I'll just forward to you in regards to opioids. I'll ask Austin to just forward that to me personally if he would do that, and I can forward that to you, and you can respond to this person. A second person said, and they actually prefaced it for Cheryl, and it simply said, "Bless you for your work." I can't say this without crying. Give me a second.
You'll make me cry.
Bless you for your work and especially for your compassion and wisdom.
Oh.
I think I'm so moved because I know you personally. And
oh, thank you, Bob.
I was leading a group today, Cheryl, before I came here. I lead one every Wednesday afternoon, and I oftentimes reference a conversation that came up in the group. And somebody made a comment in the group of how much they liked my groups, and I think you probably have a sense of me. I always will inquire, well, what is it you like? Ever the empiricist. And I think you also know me. I love being praised.
No, really?
It's not about pushing it away. I just want to know exactly what I'm going to gloat over. No, you get the spirit of what I'm saying. And one of the things that they said is there were several people that piped in, and one of the things they said is that I remember he said, "It's your intention. It's your intention." And I said, "Can you say a little bit more?" And he said, "Your intention is respect." He says, "We feel your respect for us."
Oh, absolutely. And I subscribe to addiction as a disease, no different than, say, diabetes. And we think of nothing as giving insulin to individuals suffering from diabetes.
Yeah.
Why should we judge a disease like addiction? And it's not a choice. It's not a choice. Who would choose to be an addict? No one would choose. And I think that's an important, another philosophy
we do this experiment sometimes in group, or I share this, Cheryl, and might have shared it with you before, but I just ask odd questions, I guess, I don't know, but I'll say, can you guys look at me, and can we look at each other and imagine when we were 6, And people can. I can. I can think of you, Cheryl, when you were 6. And you might still think I am 6. I don't know, but I asked that, and I said, can you imagine who of us at age 6 aspired in our lives to make sure that we became addicts in adulthood? It's just, it's obviously an absurdity. And I've had people say, can you? I'll ask them, can you go back to a time to imagine when there was innocence? And it's been very humbling to me, because I've had people say, I have to go back before I can remember. So 6 is too late. The abuse has already begun. The trauma has already begun. But it really levels the playing field for me to think of it the way you're talking about it, is that whoever signs up for this, and I fully agree with you, and I'll talk about it, and I'm sure you do this too. I talk a lot about addiction in the brain, and this idea of just saying no, or that this is a choice. There's a way that you can put it that way, but it's really problematic from a brain perspective to say that you or I or the next person signed up to be alcoholic, signed up to be addicted to opioids. And the tragic stories, and I do too. Really, really good people get sidetracked and die. And so I really appreciate, in the language of the individuals I work with, and you'll be familiar with this terminology, you would be a normie, Cheryl. And you're one of the really compassionate normies. Not all normies are compassionate, and not all addicts are compassionate either. And so I really, really honor the work you're doing. The work you're doing that's so needed in an area, in terms of rural area of your state, that if people like you weren't doing it, if Boulder Care wasn't doing it, it wouldn't be happening. And so I really honor that.
And it has to be individualized. There's no one-size-fits-all model for this. It has to be individualized.
Yeah.
What works for one person may or may not work for another person. Yeah. And I think that's another important point to mention and bring out.
People, we talk about this sometimes in the group, Cheryl, about kind of the cookie-cutter approach. There's a lot of that goes on in recovery, and I don't think it's unrelated to what we were talking about earlier in terms of kind of invasions of personhood, invasions of autonomy, and so on. Somehow it's acceptable. Cheryl, you did your research in a university, and you probably have dealt with these since. And I used to be the chair of the institutional review board at the local university, and we have protected populations, that are particularly there's huge vigilance, for example, with prisoners. With children, with pregnant mothers. I mean, there's a whole list that this is federally required, that there be exceptionally close scrutiny of any research that's going to be done. And I would add this population that we're talking about, individuals who have experienced addiction, who are seeking recovery, and I kind of, the IRB chair in me just shudders at the invasiveness of procedures and diagnostics and interventions and so on that are used. And I think this one that we just talked about, the kind of the cookie cutter, one size fits all model, is one of those particular kind of, that's a really sore spot for me. When you see people coming in from all shapes and sizes, all kinds of backgrounds, all kind of ethnicity, language, culture, religion, politics, education, and then you're going to come up with one size that fits everybody. It makes no sense whatsoever to me. So it's music to my ears to have you affirm the fact that it's individualized
Absolutely.
treatment. Yeah.
And Bob, I know we're short on time, but one really interesting phenomena that happened when we were doing some of the marketing research is I reached out to some of the individuals I knew in recovery, and for them to be a part of this program was so inspiring, and they felt so good about giving back and listened to. And we had the technology developers meeting with, individuals suffering from opiate use disorders. And this is some of the first times, when do you have people sitting at the computer meet, that the individuals they're designing the program for? And there was something like amazing happening in that room. And it was just an incredible experience.
My hats off to Boulder Care for that kind of sensibility. Really, I total respect, and they're lucky to have you, Dr. C.
Thank you. This has been great.
Yeah, it's wonderful to have you here. I'd love to have you back again. One of the days we're going to have you out here to visit with us, and then we'll have you live in the studio. But
that would
really
be fun.
appreciate that. Let this be a first conversation, Cheryl, and then things that come up that we didn't get to that are important to you, we can revisit in a few weeks, a few months. The door's always open here. I love you dearly and have total respect for the work you're doing.
Thank you.
And really feel like
if anyone has any questions, they can reach out through you, I guess. Is that the best way to comments?
What I'll have is I'll have Odie and Austin send to me. There's one comment here that I think would be more appropriate just to send to you and have you respond directly, and we can get the information from this person, and I'll send it to you. And I want to invite our listeners, if any of you have comments or questions. Cheryl, I'm going to wrap up right now. Don't go anywhere, but I'm just going to wrap up.
Sure.
If you have any questions, you can send them through Ask an Addiction Specialist right now with Austin. You can also go to my website, which is just my name, drbobweathers.com, and there's a link to my email, and many of you will do that. Just send a question to me, and if you want to earmark it for Cheryl, just let me know, and I'll forward it to Cheryl. So I'm very happy to keep the conversation going. Next week, we'll be going back to Restoring Hope in Recovery Part 2. I think actually it's going to be Part 3 because today was Part 2. I feel like I'm so moved by what we've talked about today, Cheryl, in terms of restoring hope for those that are otherwise lost and quite literally to death. And I feel like you're actively involved in the work, and Boulder Care is actively involved in the work that is really at the very leading edge of what can happen in terms of healing. There's a comment on the screen. Let me read this real quickly, and then we'll sign off. Let's see. This person says, Dr. Bob, this is to me. Oh boy, I always appreciate it when you share your personal recovery story. It helps understanding to hear someone who has your experience and wisdom to give that perspective from the inside. Thank you.
Oh, that's lovely.
Thank you.
Yeah.
Thank you. You know, the lovely thing about interacting with you, Cheryl, is that you bring such depth of clinical experience. We both do. We both have a ton of experience. I have in midlife firsthand experience. I wasn't what I signed on for. I'm not one of those 6-year-olds that thought, hey, why don't you just screw up your career permanently in midlife? Right? That was not my aspiration.
You nailed
it. Life happens, and I'm really grateful for where I am at this point in my career. But Cheryl, you're one of the good ones in terms of bringing all your clinical acumen and a huge, huge compassionate heart to this work. And so I feel like I feel really honored to work with you, and I feel like sometimes this will come up. I wonder if this comes up for you in your work. Clients will say, I'll bring this up sometimes in groups. I'll say, is it incumbent on the therapist working with you all? These are all people in recovery from substance use disorders. Is it imperative that that person be in recovery? And they say, no, it isn't. It can be helpful in the way that this person's comments. I appreciate the comments. And as a recovery coach, I'm much more self-disclosing about my failings than I ever was as a clinical psychologist. But having said that, the point they make, Cheryl, and you would fit right into this, they say, it doesn't matter to me if the person is in recovery. It matters to me if the person has the capacity to be able to hold human suffering. Can they be with the level of suffering that I've experienced? And to put it another way, can that person hold my pain with compassion? And Cheryl, you're an exemplar of that. So
thank you. And again, I just want to stress in this area, there's very few people sitting across the chair or a table from individuals suffering. And when I say there's a shortage, it's hard to imagine when you're in a big city.
Yeah, I hear you. I do hear you. Yeah. We'll continue onward, and we'll keep the dialogue going. Please pass my best to Boulder Care for all that they're doing. I really appreciate it, and I hope that today's podcast can be useful for further support for what they're doing locally there as well as across the country. I feel really supportive in spirit.
Absolutely. Thank you.
All right,
Thank you very
Cheryl.
much.
Big hug to you. Big hug.
Absolutely.
I love you dearly. You take care. We'll see you again, okay? Take care.
Okay.
Thank you all
Bye
for
now.
joining us today with Dr. Cheryl Bildner from New Hampshire. Come back next week. Next Wednesday, we'll be meeting for our next episode of Ask a Dixon Specialist. Thanks so much. Have a good week.